My name's Lance Liberty, and I'll be your presenter for today's non-surgical knee pain relief solutions presented by Sound Integrated Medical Center, located in Federal Way, Washington. They can be reached at area code 253-205-8486 to ask any questions, verify your insurance benefits, or schedule your risk-free consultation. But we'll get to that again at the end of today's presentation. Before we begin, I'd like to define what we're here for. And the purpose of our workshop today is to provide help. We're going to be discussing some non-surgical treatment alternatives that may work for you, even if you've tried steroid injections, pain medications, anti-inflammatories, even surgical interventions without positive outcomes. Also, and I feel most importantly, is to share some hope with you. The reason I'm your presenter today is actually because I, like you, was in a situation with osteoarthritis of the knee. I had early onset osteoarthritis, told I was bone on bone, would need a knee replacement. At that point in time, I was very depressed with the prognosis and thought I didn't have any options when I was introduced to one of the original FDA-approved viscosupplement medications called Hyalgin through a client of mine whose father was a doctor of osteopathy injecting this medicine. And it helped me regain my strength and function and eliminate my pain when I was told that nothing else would work. You see, I had suffered a high school football injury. Blocking on a kick return, I got hit by a helmet on the side of my right knee and kind of fell backwards over the person that got pushed into me, and I tore a few major ligaments that required surgical repair. While initially I got my function back a few years later, I lost most of the function in that knee. So I went and got an MRI to see what was going wrong, and I was bone-on-bone contact medially on the inside of my knee and was told that knee replacement surgery would be my only option by both the radiologist and the orthopedic surgeon who was working on my case. Luckily, I got introduced to this injection medication, and it worked well for me and provided many years of pain-free relief. I had another round of injections done in 2013, kind of as a fill-up, if you will, and that's kept me good and functional for another over 7 years so far. So I've been sharing my experience with others, and actually that process began with a doctor who injected my knee almost 2 decades ago. I convinced him to leave his job working for an orthopedic clinic and open a practice focused on the non-surgical treatment of osteoarthritis of the knee. And in that facility is where we developed the Advanced Arthritis Relief Protocol. This is the treatment approach we'll be discussing today, which has now been trained and certified in over 200 locations in 38 states, including Sound Integrated Medicine there in Federal Way, Washington, with Dr. Fobi and the rest of his clinical staff. So a little bit about your local provider. Sound Integrated Medical Center specializes not only in the non-surgical advanced arthritis relief protocol, but also in many different regenerative techniques, such as platelet-rich plasma, where we take a concentrate of growth factor from your own blood to help to stimulate soft tissue rejuvenation in meniscal tears, rotator cuff tears, other orthopedic injuries, as well as other regenerative tissue therapies, such as mesenchymal stem cells, amniotic fluid, and also certain other medications that are non-steroidal anti-inflammatories used for hot spots that you might be having pain and suffering from, called trigger points and so forth. The facility has radiology on site to take x-rays, look inside your knee, see what's going on, as well as video x-ray to perform guided injections that guarantee and assure the medication gets into the knee capsule or the bursa of the shoulder where it's required for your treatment. But before we get into all those fine details and the risk-free consultation offer, I'd like to talk a little more broadly about knee pain. Knee pain is a very common condition in the United States. Behind back pain, it's the second leading cause of musculoskeletal pain in our country. And it results in over 700,000 people having knee replacement surgeries in 2013, according to the CDC. Last year, that number grew to over 1 million. Many people are told that surgery is their only option, but I'm living proof that that's not true. So why is knee pain so prevalent? It affects over 40 million people at any given moment in the United States. The CDC estimates that by 2030, over 70 million Americans are going to be diagnosed with osteoarthritis of the knee. It causes hundreds of millions of office visits, billions of dollars of expense to the healthcare system, and is the leading cause of disability in the elderly as well as loss of work. Osteoarthritis is the primary cause of most knee pain in the United States. It's a degenerative condition of the bones, joints, cartilage, and it can result in pain, swelling, and loss of function in the joint. Osteoarthritis cases are on the rise quite dramatically. Over the last 25 years, there's been about 20 million individual increase in the United States. Over the next 10 years, they're expecting another 20 plus million people to be diagnosed on top of our current figures. So you are definitely not alone in your struggles. This is one of the most common degenerative diseases in the United States. In fact, out of all types of arthritis, osteoarthritis is by far the most common. It affects almost 10 times as many people as rheumatoid arthritis, which you might find to be quite surprising because when we turn on the television, most of the commercials we see for arthritis medications are for rheumatoid arthritis, like Enbrel, or for psoriatic arthritis, not for osteoarthritis, even though it's much more common. And that's because osteoarthritis has a mechanical component to it. It's not something that can be easily fixed with a pill or a quick fix, if you will. So osteoarthritis, aside from being the most common form of arthritis, is often referred to as wear and tear arthritis. And most adults over 50 years old have active osteoarthritis with some type of pain or loss of function. I've found over the years in looking at thousands of x-rays throughout the facilities we work with that most people 35 and older actually have some early signs of osteoarthritis. And osteoarthritis actually starts out as what I like to call a drying problem, because before you have loss of your cartilage and destruction of the bones and hard tissues, there's a fluid-filled capsule called the synovium that is your first line of defense and cushioning and lubrication of the joint. And the dysfunction begins there before these hard tissues ever become damaged. So why the knee? Well, we've been using it regularly since we were about a year old and started walking. It bears about 80% of our body weight on a daily basis. Osteoarthritis can be exacerbated and happen early onset because of injuries like the sports injury that I suffered from, or if you're in an auto accident and hit the steering wheel or dashboard, if you have a big fall and your knee hits the concrete, or even from accumulation of little micro traumas like bumping your knee on a coffee table can damage the synovial sites, the little glands that produce the hyaluronic acid and synovial fluid inside that joint capsule. As we age, the more mileage we put on our knees, the more likely we are to have dysfunction. The more we weigh, the more likely we are to develop dysfunction because we're putting a greater load over time on the joint. And then also deformity. If you've ever heard the term knock-kneed or bow-legged, that is kind of the common speak for a varus or valgus deformity. And you see our knees commonly fall out of alignment. About 85% of people have a medial loss of joint space and misalignment. About 15% have a lateral or external loss of joint space and alignment on the outside aspect of the knee. So I like to use automotive analogies. They tend to be very relevant to the problem that we're suffering from with the knee. And if you've ever had a car where your alignment went bad, you've noticed that you go through tires really quickly because you have an uneven wear. If you're asking just part of that tire to bear the entire load versus the entire surface area, it fails much more quickly and will eventually lead to a blowout if you don't fix that alignment issue. Well, our knees are not extremely different from that. They can bear weight very effectively. It's what they were designed to do. They can go front to back for a long, long time without a problem. It's once you start introducing an uneven load or rotation or sheer lateral movements that the knee begins to fail. And that's why in sports, you see most of the knee injuries are not from a head-on impact or collision, but from a side impact or collision, because the joint's not designed to bear as much stress and weight on that angular plane as it is on a front to back motion. So let's look at an anatomical drawing of the knee real quick, just to talk about some of the normal structures. This triangular shaped thing you see here is your patella or your kneecap. And it's designed to ride in between this channel here, in between the femoral condyles, much like how a sliding glass door goes smoothly on its track. But if it ever falls out of track, it can grind and be very difficult to move. Your kneecap is not much different than that. This white substance you see here surrounding the end of the bones is called hyaline or articular cartilage. And that's designed to protect the blood vessels and nerve endings that wrap the bones and keep them from becoming exposed and damaged. In between the joint, you've got a meniscal soft cartilage, and then you also have this synovial fluid that will cushion and lubricate the joint, allowing it to glide next to each other. You see, when all of our joints are working properly from our fingers to our toes, they don't actually touch each other. It's not like a door where there's a hinge and there's a physical friction every time you move it. all of our joints actually are designed to glide next to each other. They're not like a hinge. When you have a breakdown of the joint, you can wear away those structures, eventually exposing the underlying components, such as the blood vessels and nerves. So before we get to the damage of the soft cartilage and the hard tissue and the bone, we want to look at this fluid-filled capsule called the synovium. And inside the synovial membrane, there are these little glands that produce the synovial fluid. And inside the synovial fluid is an ingredient called hyaluronic acid. And hyaluronic acid is very special fluid. It's actually a non-Newtonian fluid, meaning it doesn't follow the laws of physics. Typically, if you take a boat and you put it in water, it displaces the water and it floats. If you were to take that same body of water and drain it and fill it with hyaluronic acid and try to launch the boat would tip over, because as you compress hyaluronic acid, it becomes more dense and it resists that compression. So it's a very special type of fluid that are inside our joints. It's not just like water or a normal fluid. And this is what allows the bones to glide next to each other and not come into contact, and keeps everything nice and healthy and strengthens the cartilage and so forth. This hyaluronic acid not only cushions and lubricates the joint and acts as a shock absorber, but it also nourishes the cartilage. It keeps the cartilage very elastic and able to rebound and able to suffer small traumas and recover from them. But over time, as the synovial fluid goes from a thick consistency to a thinner consistency, it allows the bones to move closer together. And as that happens, it creates friction, and the friction will wear away the soft cartilage, the meniscus, eventually the hard cartilage, the hyaline cartilage, and then beyond that, the bones themselves. So if you've been told you have a bone spur or an osteophyte, that's a sign that you've worn through some of that protective hard cartilage, and the bone is now trying to regrow and thicken to deal with that extra pressure and impact that it is suffering from. If you've ever bent your knee while going up and down stairs, getting in and out of a car, etc., and it's felt like it's caught or latched and then releases, you're probably feeling little pieces of the loose cartilage or bone getting stuck and then grinding past them as you go through your range of motion. So those are some telltale signs that you might be suffering from more advanced osteoarthritis. Now, if you're feeling any type of electrical pain that might shoot down your calf into your foot or up your thigh into your buttocks or low back, that's most likely because you've worn through your hyaline cartilage and exposed the underlying nerve endings that wrap the bone. It's not much different than if you've ever chipped your tooth and had that very sharp pain from the nerve being exposed. So if you've got that type of electrical pain, you've probably worn through your hyaline articular cartilage. So before we get into some of the treatments for osteoarthritis that you may have tried and failed, and how the advanced arthritis relief protocol is a unique non-surgical alternative, I'd like to look at some x-rays from actual patients. These x-rays were provided to us from two of the centers that we certified here in Orlando, Florida. And before we get into the osteoarthritic x-rays, I'd like to show you a normal x-ray, because it's hard to tell what's wrong if you don't know what's right. I remember when I got my MRI years ago, they put it up on the screen and told me why I was so bad and why I had to have surgery, but they never really explained specifically what was wrong or what it should have looked like and why it didn't look that way. So we're looking at two x-ray views here. One is called the AP, or anterior to posterior front to back view, and the other is a lateral side view. Let's start with the front to back. This guitar pick shaped structure here, that's your patella or your kneecap, and you can see it between the two femoral condyles, just like in the drawing we saw a few slides ago. You can see the thick hyaline articular cartilage covering the bone there. These soft, rounded mounds here in the middle are called your tibial spines. All this black that you see in between the joint, X-ray shows hard tissue. And the more bright and white something is, the more dense that tissue is. All the black that you see is not empty space. That's where your meniscus is. It's where your synovial fluid is holding that space open. And then lastly, if we kind of trace the outlines of the bones, we can see that they follow the same pattern and are in proper alignment. Now, if we look at the lateral x-ray, we're trying to see, does this patella, does this kneecap have space between itself and between the femur bone here, which it does. So this is a normal knee x-ray. Now let's look at abnormal. In early osteoarthritis, also called Kellgren-Lawrence grade 1 osteoarthritis, you can begin to see a little loss of joint space. And if you look at that kneecap, it's slightly out of alignment, still in that channel, but a little more outside than it should be. Because as you suffer from osteoarthritis, most people have this deformity where the femur bone starts to move inward. You would think your tibia, your shin bone, would be what moves out of alignment, but actually it's the large bone, the femur, that typically moves out of alignment in the joint. So we can see that moving inward, compressing that space, and the kneecap being slightly out of alignment as a result. In grade 1 osteoarthritis, you're probably not feeling any pain or suffering from any symptoms. It's the early portion. Around grade 2 is typically when people start to feel pain, soreness, stiffness, swelling, and other uncomfortable symptoms, not necessarily debilitating symptoms. And at this portion of the disease, there's a little more loss of joint space. You can sometimes see tiny osteophytes or bone spurs beginning to form. You can see those tibial spines that used to be smooth and round like the Appalachian Mountains are now sharp and pointy like the Rockies, and they're wearing away. The kneecap's still in pretty good alignment here. And this is where you'll get intermittent pain. Now, if you have pain all the time, you've probably progressed to Kellgren-Lawrence grade 3. So this is where the knee's further out of alignment. You can see the kneecap over here. With this much of a misalignment, you'll probably hear clicking, cracking, popping, all types of different noises coming from your knee when you bend it and do certain activities. And what you're listening to is your kneecap actually grinding over your femur bone and that impact taking place. You can see the osteophytes a little larger here, a little easier to see. Those tibial spines have been worn away, and there's a lot less joint space available. At this stage, you might even have to use a cane or ice your knee regularly. It might keep you even from doing certain activities like golfing, dancing, or more strenuous type motions. At Kellgren-Lawrence grade 4, which is the most severe stage of osteoarthritis, you've progressed to a point where you may be bone on bone. You've got large osteophytes. You've worn through the cartilage. The kneecap's even further out of alignment. Typically, people that are at this stage of the disease are using a walker or a wheelchair or can't even walk at all and are wheelchair stricken. So if you're not using a walker or a wheelchair and you can still move around, you're probably grade 3 or lower. But I'm going to show you an x-ray today from a patient who was in a wheelchair, unable to walk, very badly bone on bone, Kellgren-Lawrence grade 4. And we were able to help her return to normal function and walking under her own power and many other great improvements. I will show you that pre and post x-ray before we are done here today. So even if you are in a wheelchair or a walker, don't despair. This treatment may still work for you, even if other treatments have failed in the past. Now, before we move on, I want to show you what a partial knee replacement looks like for a few reasons. If it turns out that you come in for your risk-free consultation and you really are that badly progressed with the disease, that injections and alternative treatments will not work for you, and you have to receive a surgical consultation, remember a partial knee replacement. They only compromise about 5% of the knee replacements performed annually in our country. I make the argument it's not because they're less effective, but because they're less costly, that they are underutilized. But a partial knee replacement makes a lot of sense. It replaces only the half of the knee joint that has gone bad. And if you go back to these x-rays we were looking at, one side was always much more worse than the other, right? So if both sides haven't gone bad, why replace them both? Let's just replace the bad half. And the beauty of a partial knee replacement, even if you've had one before and you still have pain, is it leaves the synovial capsule intact. That fluid-filled structure is stitched back up and remains in your body after a partial. So if you've had a partial and your pain returns or it didn't work all the way, you can still have injections and treatments like our advanced arthritis relief protocol, and you don't have to go back under the knife a second time. I'll show you a little later a total knee replacement, and in those, they remove that capsule completely, so you run out of non-surgical alternatives. So that's what a partial knee replacement looks like. So where does Sound Integrated Medical Center and Dr. Fobi and his team come in? So the advanced arthritis relief protocol is meant for when other conservative care has failed. You've been taking ibuprofen every day, Advil. You've tried hot and cold. You've tried to lose weight. You've tried exercise or rehab. Maybe you've even had cortisone injections and those haven't worked for you. Well, the specialized unloading, bracing exercise protocol and joint fluid therapy that will replenish that synovial fluid and help to give you an opportunity to regenerate cartilage and normal tissue is a great next step prior to undergoing surgery. And you can know that you've exhausted all your options if you do have to go under the knife after going through a protocol like this. In fact, many insurances, such as Medicare, are now requiring patients to try and fail intra-articular injections, bracing, and therapy before they'll cover the surgery. Whereas prior to May of 2017, that wasn't a requirement. The surgeon could go right to that more invasive approach without trying these other less invasive, less risky, and less costly alternatives first. Now, we combine these treatments into a uniform protocol where they're done at the same time. You get the injection on the same day the brace is applied to increase the joint space and allow that injection to be more effective. And exercises are given for you to do at home. Therapy might be applied in the clinic. We might follow these injections up with regenerative medicine techniques like platelet-rich plasma to help you grow your cartilage back faster. Now, the reason I'm making such a point on this is usually in healthcare, you try and fail a single treatment, then move on to another. Oh, therapy didn't work, let's try cortisone. Oh, cortisone didn't work, let's try bracing. Well, we had the bright idea that if these things individually are somewhat effective, couldn't they be more effective if we did them all at the same time? So that was what the Advanced Arthritis Relief Protocol really began as, and it turned out to be much more effective than doing these treatments separately. So let's look at some of the things you may have tried and failed in the past, like pain medications, Vicodin, hydrocodone, tramadol. These medications are opioids or other derivatives that are designed to slow down the rate at which your nerves transmit information. It's not fixing what's causing the pain, but it's making it more difficult for you to sense that pain. So it's covering up the problem, not necessarily fixing it. And the problem with pain medications is they tend to be very risky, not only in their habit forming nature. Most people in our country that are addicted to some type of an illegal opiate started out on a legal one where they got a prescription as a result of an injury or a surgery. And these are very, very strong medications. They can create a physical dependence of your body. But they can also cause some pretty serious side effects because they don't just slow down your nerves, they slow down all functions in the body. That's why the bottle says may cause constipation for 2 weeks or longer. It slows down your GI system. It makes it more difficult to breathe. And you might feel foggy or less sharp mentally because it's slowing down the axons and the neurons in the brain as well, not just the nerves that are transmitting pain signal. They're slowing down the regular nerves too. So for all those reasons, pain medications, especially used over an extended period of time, are quite risky. Now, what about the over-the-counter stuff that doesn't require a prescription? Tylenol, acetaminophen, Advil, ibuprofen, or Aleve, sodium naproxen. Well, this family of non-steroidal anti-inflammatory drugs, or NSAIDs, they're relatively safe. I mean, they have baby Tylenol. You can give this to infants under certain scenarios. And the thing with these medications is they're very safe in smaller doses and shorter periods of time. But if you're taking 6 to 8 ibuprofen a day, like I was for months and months and months, maybe even years, that's when you can start having the liver damage, the kidney damage, the serious side effects. And I learned about the risk of long-term use of NSAIDs when my daughter was a baby. She had her first fever and her first real sickness. And being new parents, my wife and I rushed her to the emergency room and thought it was the end of the world, didn't know what to do. And they go, give her Tylenol and give her Motrin every 4 hours, switch between the two. And I said, okay. So I go to the pharmacy, buy these medications, and I decide I really want to get this right. I'm going to read all the instructions. So I peel the label back, I read all the instructions, and something really interesting was in those instructions that said, should not be used for more than 7 consecutive days. And I thought, holy cow, I was using ibuprofen for months. I didn't know that it became dangerous after 7 consecutive days. So when you look at the 30,000 plus people every year that die in the United States from Tylenol, it's not because Tylenol is inherently risky. It's because they were using a lot of it over an extended period of time, not the way you're supposed to use the medication based on the labeling guidelines and instructions. So that's where those become risky. So if you don't want to use these oral medications, looks like surgery is your only option, right? Not anymore. There are many other things that can be tried before surgery. And when you get to surgery, it's not always a guarantee it will work. These knee replacements are not made specifically to fit you. They come in standardized sizes. In the total knee replacement I'm going to show you the x-ray of, you can see the bone hanging over the edge of where the hardware was installed. they also tend not to last for an extended period of time. About 50% of patients have some recurrence of pain and loss of function after 2 years, and most knee replacements last for about 8 to 12 years, depending on your weight, body morphology, and other factors, because this is hardware. Just like you have to change the tires in your car every 40,000 miles, the metal and plastic used for these artificial joints aren't permanent. So if you are younger, especially if you're in your 50s or 60s, you want to try and delay that knee replacement surgery as much as possible because you're likely to outlive the hardware. And then there's the dangers associated with anesthesia. Now, I like to break surgery results up into 4 equal quarters for simplicity. About a quarter of the people that had a knee replacement think it's the greatest thing they ever did. Their pain is gone, their function's back, and they're very, very, very happy. Another quarter of patients, they've got some improvement in pain, but not a full resolution. Another quarter didn't have much change at all, and the last quarter actually got worse. You see, sometimes you're trading off the pain from the hard tissues with the pain from the soft tissue. When they cut you open, when they stitch you up, that creates scar tissue, and that can restrict range of motion. That can be painful. So the knee replacement is not necessarily a guarantee that it will work. So here's that partial knee replacement x-ray again, and here's the total I promised to show you. In a total knee replacement, they cut off the top of the tibia and put a plate in there, typically a metal plate of nickel or cobalt, and they screw it into the bone and anchor it into the bone marrow. That's what that spike is there. For the femur, the thigh bone, they typically use some type of a cap on top of the femoral condyles. It could be a polymer and a plastic, or it could be metallic as well, just like this plate. And your synovial capsule is discarded. So that cushioning and lubricating property is gone. Now you've just got these hard structures that grind together and eventually wear away. And here you can see where that femoral condyle is kind of sticking out, that tibial plateau is sticking out. This didn't perfectly fit the patient's knee. And unfortunately, this is what most TKA x-rays look like. So what about those dangers of anesthesia? Well, it's not just the risk of not waking back up that's very small. It's also something called postoperative cognitive dysfunction, or POCD. This is a condition that creates Alzheimer's or dementia type symptoms and increases your risk of strokes and other cerebrovascular events because not everyone metabolizes anesthesia the same way. You know, I'm sure you have that friend that's very skinny no matter what they eat, and know someone that's really heavy no matter how much they diet and exercise. Well, they have different metabolisms, right? So if you've ever heard of people that wake up during surgery, they have very fast metabolisms. But for people like me and most of us that have a slightly slower metabolism, we might not fully metabolize that anesthesia for hours, days, weeks, even months. So you can wind up for up to half a year suffering from some of these cognitive symptoms. And it's not because your brain's gone bad, it's because you're still metabolizing this anesthesia. So another thing to keep in mind as a risk factor and why you might want to delay or avoid surgery. But we're not here to scare you. We're here to help you avoid these drug surgeries and complications with a less costly, safer, and more effective alternative called the Advanced Arthritis Relief Protocol. And it doesn't just cover up the symptoms like pain medications or steroids or anti-inflammatories. It gets to the root cause. So if osteoarthritis is a drying problem, let's talk about why that causes everything to break down. If you take a sponge and you get it soaking wet and try and rip it in half, you can't do it. This sponge is elastic. It rebounds. If you crunch it up, it springs back to its shape. It's just a very resilient structure. Well, our meniscal cartilage, when it's properly lubricated, is also very strong like that sponge. Now, if we let that sponge sit next to the sink for 2 or 3 days and be still damp but not soaking wet, and we try to rip it, we probably can. If we crumple it up, it may not spring back as quickly or as fully as it used to. Now let it sit by the sink for another 2 or 3 days and dry all the way out. And you can put it in your hand, close your hand, and it's going to crumble up like dust real easily. That sponge lost all of its elasticity. It lost all of its strength and structure because it wasn't properly lubricated and it didn't have the nourishment of that fluid. So our cartilage very much is in a similar situation. As this synovial fluid wears away and has less hyaluronic acid, it's not just that we're moving closer together and getting more friction, but those cartilages become weaker at the same time, and it exacerbates the situation and leads to the symptoms and pain and discomfort and loss of function that you might be suffering from, just like I once was. So as that fluid changes from very thick to very thin and water-like, It allows that friction, it allows that breakdown. So wouldn't it make sense just to fill that joint capsule back up with a nice thick fluid again? Not a trick question. This is actually what we're proposing, something called joint lubrication therapy or viscosupplementation. And the idea is that we're going to not only replenish that fluid, but teach the synovial in the body, retrain them, and stimulate them to make more of that fluid and more of that hyaluronic acid on their own. Again, now, not all joint injections are created equal. There are big differences. If you've had steroid injections before, this is not the same thing. Steroids or cortisone work by drying out the area of which they are applied to. So if you've got a drying problem, wouldn't this make it worse? That actually is what happens. And if you think about it, if you ever had a sinus infection or a respiratory infection, and it was a very productive cough, and you had mucus and phlegm, the doctor might have given you prednisone or an oral steroid to take. And within a day or two, that all dried up and you were feeling much better, right? Well, injectable cortisone works very similarly. And if you've ever had an injection of cortisone before, you might have noticed that it stung or it burned because it's very acidic. And it can actually break down the tissue around where it's injected and lead to osteoporosis, up to an 8% loss of bone in the 4 months following the injection. It's also derived from sugar. The full name of steroids are glucocorticosteroids. Gluco from glucose. Cortisone is actually derived from a sweet potato that's found in the Amazon rainforest in South America. So when our body breaks it down into its individual components, it causes our blood sugar to spike, which is why if you've ever had a cortisone injection or taken cortisone pills, steroid pills, you probably had a lot of energy shortly after that, or maybe had difficulty sleeping. That's from that sugar impact and the energy that comes from it. But repeating that over a period of time can not only exacerbate and make diabetics more at risk, but it can create cataracts and other problems from areas where there's concentrated vascular supply in the body. And then lastly, cortisone can suppress your immune system. If you think back to the last time you had to take prednisone, when you had an infection and some mucosal buildup, it says right on the bottle that you're more likely to potentially contract a bacterial or viral disease. Well, we're dealing with a big virus globally right now. We definitely don't want to do anything that makes our immune system less strong. So for all those reasons, avoiding cortisone is a good idea because while it might provide short-term relief, it's actually going to make the problem worse over time. Now, if you've got what's called a joint effusion where your joint's swollen and the physician drains the fluid, well, that's an appropriate time to use cortisone. But you don't want to use cortisone as a treatment for chronic disease. It's meant for acute conditions, just like those over-the-counter pills. In fact, the Food and Drug Administration states that you should not have more than 3 injections of corticosteroids at any point in your body in your lifetime because of those risk factors associated with it. So if you've had more than 3 injections of cortisone, you know that you are significantly at risk for these side effects. Some food for thought. So let's get back to the solution. Better idea, changing the joint oil. Medical term for this is called viscosupplementation. I had Hyalgin, one of the first FDA-approved viscose supplements. It was approved back in 1996. I think I had my first injection around 2000. Had a second one in 2013, second round, and I'm probably due for another round now. I'm starting to get some clicking and popping and soreness in that right knee again. It lasts for about 7 years for me each time I have it done. We tend to use the medication, a newer medication, FDA approved in 2015 and being covered by Medicare starting in 2017, called Genvisc 850. Some of the early medications were derived from the rooster's comb. Sometimes you hear people call them chicken shots. And then there were some synthetic products like Synvis made from a chemical process. Well, now there are these biological products that are made from bacterial culture, and they don't have the side effects, risk factors, or allergic interactions of those original avian-derived products. Now, before I proceed, I just want to play a brief 2-minute video that's going to show the procedure being performed under guidance and with some of the co-treatments like the bracing and therapy we use, so you can better understand the type of treatment that you're going to be evaluated for if you go into sound integrated medicine for your risk-free, no-cost consultation there in Federal Way.
Osteoarthritis, also known as degenerative joint disease, is the most common type of arthritis. With osteoarthritis, the surface layer of the cartilage breaks down and wears away. This allows the bones under the cartilage to rub together, resulting in pain, swelling, and loss of motion in the joint. Although in some people it progresses quickly, in most individuals, joint damage develops gradually over years. Viscosupplementation therapy is a non-surgical outpatient procedure by which a pain relief medication called Suparts is injected into the knee joint. This medication mimics the body's synovial fluid of the knee that lubricates the cartilage. Suparts will help the knee to move smoothly, reducing or relieving the pain of osteoarthritis. In preparation for the injection, the physician sterilizes the knee and administers a local anesthetic. The physician positions an imaging device called a fluoroscope over the knee. The fluoroscope will display a moving X-ray of the inside of the knee that will ensure the Suparts reaches the joint space. The physician carefully guides a needle to the joint space. The physician confirms the placement into the knee joint with an injection of contrast dye. The contrast dye is clearly visible on the fluoroscope image. If the dye pools in the soft tissue at the front of the knee, the physician will adjust the depth and angle of needle placement until the joint capsule of the knee is reached. When the contrast dye flows through the joint capsule, the physician knows they are ready to inject the Suparts. While leaving the needle in position, the physician removes the contrast dye syringe and replaces it with a syringe filled with Suparts. The physician injects the Suparts into the joint space within the knee. The Suparts will bond with the synovial fluid inside the joint, cushioning and lubricating the joint. When the injection is complete, the physician removes the needle and bandages the knee. Ice is then applied to reduce swelling. Suparts is administered in a series of 5 injections 1 week apart. Pain relief can be immediate and has been shown to last for 6 months or longer. In addition to the Suparts injections, knee bracing and physical therapy are utilized to enhance the effects of the medication.
So hopefully that gave you a little bit of a visual understanding of the treatment and what we do. Now I want to talk about some of the individual components of it real quick, starting with the medication itself, Genvisc 850. Now, if you've had other viscosupplement injections in the past that haven't worked for you, typically we find that needle misplacement's a big contributory factor to that, as well as not having bracing or therapy applied at the same time. But there is even a difference in the medications. You see, Genvisc 850 has been proven effective over a 40-month period, with more than 80% of the patients still having pain relief and improvement in function. And it's the correct molecular weight to bond with your synovial fluid. This 850 stands for 850 Daltons, the molecular weight. And clinical research and trial has shown that molecular weights of 750 or higher have greater clinical outcomes than those that are lower. It's been used over 45 million times in 64 countries without ever having a side effect or allergic interaction, because it is avian free, not chemically manufactured, and so safe it's labeled safe as saline placebo by the Food and Drug Administration in the package insert that comes with the syringe. Now, the next aspect of what we do has to deal with the guidance of the Genvisc 850, because if you don't get into the synovial capsule, there's no chance for it to cushion or lubricate your joint or to bond with the fluid-producing synovicytes to create the stimulation of more hyaluronic acid and synovial fluid by your body itself. So we wanted to bind with these cells and create that stimulating effect and get that joint fluid from a thin water-like consistency back up to a thick oil-like consistency once more. And we know in this longitudinal study, not only is it extremely safe with no adverse events or side effects, but after a 40-month follow-up, more than 80% of the participants had some improvement of function and reduction of pain still, so it's long-lasting. Prior to this study, most of the research only followed the treatment 6 months out. More good news, viscosupplementation is all natural. It's not a drug, so it's not going to interact with any other medications that you're taking or cause any side effects. It's also so safe that it's used as placebo in diabetic research. The problem with these medications is they do have to be injected directly into the joint where you're having the problem. It's not something you take orally or that will find its way to the issue. In fact, if you don't have proper placement, it won't work at all. And that's really the catch associated with this. If you've had viscosupplementation in the past, but it didn't work for you, not only is the type of medication injection going to play a role, but how the medication was injected is going to play a role. Did you see it happening? Was a fluoroscope or an ultrasound used to see the needle inside your body? Was a contrast dye used to confirm needle placement? See, we never guess with the advanced arthritis relief protocol. We can guarantee positive needle placement through using video x-ray and this contrast dye. Because according to the American Journal of Sports Medicine, without guidance, about 21% of injections into the knee and more than half into the shoulder fail to reach that capsule. And if you're not inside that capsule, the medication has no chance of working. When imaging is used, it's over 99% accurate. Now, I argue that in our facilities, it's 100% accurate because we use video fluoroscopy devices like the one pictured on screen here. And this doesn't just allow us to take an x-ray of your knee, it also allows us to see the needle in real time as it approaches the joint capsule. This solid line you see here is the needle, and this little black substance here that looks like the Batman logo is the contrast dye spreading out. And you can see that dye flow to the posterior of the capsule here, and up into the anterior of the capsule and behind the patella here. So the physician always knows the needle's in place before the medication is administered. This is the biggest determining factor on whether or not these injections will work. So our advanced arthritis relief program is very simple. We follow the research, we do what is right, we only accept those who we think we can help, which is why a risk-free consultation is offered to you, and there's an extremely high positive outcome. This slide says 75%, but in a randomized case study we did of 384 patients across 2 locations in Florida in 2015, only 1 patient had no improvement, and 356 of them, nearly 93%, had a 50% or greater reduction of pain, improvement of function. And that's just from a single round of injections. And that include the people that were much more involved and more progressed in the disease, not just the simple, easy cases. So we have this 3-pronged approach that uses video guidance to get the Genviscate 50 or viscosupplement required by your insurance carrier into that capsule. We use exercise and physical therapy, very simple exercises that can even be done in the comfort of your own home, not leg presses and lunges and things that can make it more painful and symptomatic, to strengthen the ligaments and the muscles to help bring that joint back into alignment. We also use a special unloading knee brace to increase that tibiofemoral joint space, stop that friction, give room for your body to grow back the cartilage that's been destroyed, and help turn back the clock on the damage to your knees or shoulder. Now, our program is covered by most insurances, including Medicare, and this approach of doing everything at the same time really helps tremendously, because if we inject the medication into this knee, it's going to want to go to the area of lowest pressure here. Well, we need it to go to the area of highest pressure where all the structures have been compressed and destroyed. So by providing the unloading knee brace, it opens that joint space up, draws that medication into that compartment, thereby cushioning and lubricating and stopping further damage of the joint in that area. Now, this is that 2-year follow-up of the patient that was bone on bone I promised to show you. She was an 86-year-old female at the time we took this x-ray here, very badly bone on bone, in a wheelchair, not able to walk under her own power, in a nursing home, and not a candidate for surgery due to this titanium rod installed from a previous femur break. Here, 2 years later, we have the same patient, but you can see that there is some joint space present. And remember how we said everything on x-ray that's bright and white is more dense? Well, look at how much more dense her bone is and how much more dense her muscle is. Well, she had lost over 60 pounds, was walking under her own power, exercising again. So it wasn't just reducing the pain, all those other problems that she was suffering from cleared up. In fact, her diabetes and her heart disease became more easy to manage with this weight loss and with this movement. And she was able not only to get out of the wheelchair and walk under her own power again, but to move to an independent living facility and no longer having to be in a skilled nursing facility. So even in very extreme cases, this can work, but we know that no 2 knees are the same, and that what you've tried might be different than what someone else has tried. And that's why we offer an individualized, risk-free consultation where you can come into the office at no charge, meet with a clinician, explain what you've tried and what you're dealing with. They can explain what they might be able to offer and see if maybe we can help you get back to the activities you can no longer do, such as dancing, golfing, or even just walking the dog or going up and down your stairs again. And what if you've tried visco supplement in the past, or what if we do this and it doesn't work? What about that 7% from the research study that didn't have a significant improvement? Well, that's where the regenerative medicine comes in with human cell therapy and with platelet-rich plasma. This x-ray is from an 88-year-old male patient in one of our clinics in Western Pennsylvania, just outside Pittsburgh. And on the left-hand side there is after 5 injections of Hyalgan. On the right-hand side is 3 months later. That's after 3 injections of PRP once a month for 3 months and an injection of amniotic fluid. This patient was not only able to regain their joint space, but significant function. In fact, he went golfing again after not having done so for more than 17 years. Very happy about that. Now, this x-ray was from back in March of 2017. This patient paid cash for this service, about $6,500, because insurance didn't yet cover amniotic fluid and some of these injections. Well, I'm happy to report to you that today, many of these regenerative techniques are covered by some insurances, such as Blue Cross Blue Shield, Humana, United, Medicare, and TRICARE. So if you require an amniotic injection, it might be paid for by your insurance. And if you require PRP, well, it's a very inexpensive treatment option, hundreds of dollars, not thousands of dollars, that can be afforded by most and financed very inexpensively if need be. Now, when you come in for your risk-free consultation, we offer a variety of solutions for these different presentations because we know what works in each situation. If you're bone on bone, we know that hyaluronic acid injections and bracing are going to help build that joint space back up. But what if you've lost your meniscal cartilage or a significant portion of that soft cartilage? Well, yes, it'll regenerate on its own. With a platelet-rich plasma injection, we know it will regenerate much faster. And what if you've worn away that hyaline hard articular cartilage? Well, we know that grows very slowly. So using an injection of amniotic fluid or mesenchymal stem cells might help that tissue to regenerate faster. And with the platelet-rich plasma, because about a third of the patients suffering from osteoarthritis do have some meniscal involvement, just want to explain briefly how it works and how it's so cost-effective. We began manufacturing our own line of FDA-cleared platelet-rich plasma harvesting kits about 4 years ago. And these products allow the clinicians in the field to take a small sample of your blood, 10 mLs, the same amount you give annually for your checkup with your primary care doctor, and concentrate the growth factors and the serum from your plasma. Now, if you've ever cut yourself, after that red blood cells stop flowing, you see kind of a clear or yellowish fluid come out, and that forms the scab. And a few days to a few weeks later, depending on the severity of your injury, that scab will fall off and there'll be new skin tissue where you used to have that cut or that wound. Well, that clear yellowish fluid carries the growth factors and all the healing potential of our body through our vascular system. Whether we cut ourselves or whether we have an internal injury, this is our first line of defense and recovery. So we can concentrate that and inject it into the meniscus or where you've had soft tissue damage to help it regenerate and recover much faster than it would on your own. So what's the next step? To schedule your risk-free, no-cost consultation. If you'd like to take advantage of this, just type yes and the best phone number to reach you at into the chat box or the Q&A box now. You can also schedule online at www.soundimc.com or by phone at area code 253-205-8486. Again, that's 253-205-8486. Your initial consultation will be conducted by one of the licensed medical providers, whether it be Dr. Fobi or the nurse practitioner Caitlin, or the rest of the medical team. These are all highly experienced individuals that have also been trained and certified in the advanced arthritis relief protocol that we've discussed here today. So before we close out today's presentation, I'd like to take a minute to answer questions that anyone might have. So if you've got a question, you can type it in at the top of your screen. There's a little box that'll say Q&A, and you can, let me see if I can get there, here we go. And you can type your question in there. You can also ask your question verbally. You'd hit the button to raise your hand, and then after we answer the typed questions, we'll call on you one by one to answer those questions. So starting with the questions, the first one from Mike is, what is the treatment cost? Well, Mike, it depends on your insurance. Most insurances will cover most or all of the expense associated with the injections of the visco supplement, the unloading bracing, the therapy, or rehabilitative exercise. If you have Medicare and a secondary insurance, you'll probably have no out of pocket. If you've got TRICARE, you were a military or family member, no out of pocket. Commercial insurances can vary. One of the things that will be provided to you is a complimentary verification of your insurance benefits. So if you call in to schedule your consultation at 253-205-8486 and you give them your insurance ID number, the staff will be able to check what type of benefits you have and let you know when you come in for that risk-free consultation if you have any copay, coinsurance, or deductible remaining. So that can be covered. If you don't have insurance at all, we might look at the regenerative medicine techniques first, like platelet-rich plasma, because it's very inexpensive before getting into the injections of viscosupplement. But let's say you are bone on bone, you do need those hyaluronic injections and that bracing. We might use a less expensive hyaluronic acid medication like Hyalgin or Suparts, or even a compounded hyaluronic acid to keep your coinsurance down to at or below about $100 a visit for the medication. Overall costs can be discussed with the physician. Different medications are injected different times. Some are 1, 2, 3, or 5 injections. People without insurance, we might move to a less costly and shorter treatment plan to try and reduce your out-of-pocket costs. Another question from Mike is, how does it compare to stem cell? Well, stem cell therapy is part of our treatment tools that we might use, but we use it in the right way at the right time. And what I mean by that is if you're bone on bone, and you've got these bones rubbing together and you're creating bone spurs, the stem cells might not behave the way you want them to. In other words, what I mean is stem cells are alive. If you do a stem cell transplant from a tissue bank product, or if you derive it from your own bone marrow or adipose tissue in an autologous treatment from your own body, the first thing stem cells do when administered is called homing. They're attracted to cell depth called apoptosis or inflammation. So if you've got a lot of destruction of bone, they might signal to become osteoclasts and start creating more bone tissue and actually make those bone spurs worse. Well, that's not how we want the stem cell to work. We want the stem cell to build new cartilage, right? So oftentimes we'll put patients in bracing or do hyaluronic acid injections before using stem cell, because that'll help to coax the stem cells to behave the way we want them to. We also usually reserve the stem cell treatment to be the last thing we try, because it tends to be the most costly treatment option for the patient. So we try the things that are least costly, least risky, and only progress to those other treatments if they're truly necessary. Karen asked specifically if Kaiser Permanente covers this. Great question. I am speaking to you from Tampa, Florida today. We don't have Kaiser down here. I have some clients in Maryland and Virginia and over in the West Coast and so forth where it's very prevalent. So make sure to give your insurance ID information to the staff when you call in to schedule your consultation, and they will verify your benefits and tell you what your out-of-pocket costs might be, if any. Now, almost all insurances cover viscosupplementation, so you probably do have benefits from your Kaiser plan, but the practice can confirm that for you. Mike also asks, is the X-ray covered in the free exam? Great question. So the free consultation consists of reviewing your systems and your history, and the physician telling you a little bit about the treatment and kind of a big picture. Does it sound like you might be a good candidate for this? Is this something you might be interested in? When it comes to the step of the X-ray, at that point, we would bill the X-ray to your insurance if it was required. Now, if you've had an X-ray and MRI in the past 6 months, you can bring it with you and it will be reviewed free of cost. But if one has to be taken in the office, that would be billed to your insurance. Now, if you don't have insurance, the cost out of pocket for the knee X-rays is about $45. So it's not very expensive if you don't have insurance to have the X-ray, but that typically is going to be billed to and paid for by your insurance. Michael asks, you had a meniscus tear about 8 years ago. You recently appeared to have had an arthroscopic surgery that took out some of the scar tissue, and now you've got an offset of the knee and you're getting some of that rubbing from the misalignment. So while your case is a little more complex, I can speak from experience that it's likely to work for you. I mean, I had 2 arthroscopic surgeries and 1 open surgery, and I had a significant amount of meniscal involvement and even had part of my meniscus removed surgically prior to having the injections of hyaluronic acid done, and it worked great for me. Now, every case is different. You might be more severe than what I was dealing with, so make sure to bring your medical records with you when you come in for your risk-free consultation, especially if you've had any imaging done after that last arthroscopic surgery, like an MRI or an ultrasound examination where we can see the soft tissue. It'll make it much easier for Dr. Fobi and his team to make accurate recommendations for your treatment if they've got that. If they don't, again, we can take the x-rays on site if you don't have access to that imaging. So I hope that answers your questions. So it doesn't look like there's any more typed questions that haven't been answered. So if somebody would like to ask a question verbally by phone, if you just want to click that button to raise your hand, Tina, the coordinator that's helping to host this with us here today, can unmute you so we can ask that question. While we're waiting to take verbal questions, I just want to repeat, if you do want to come in for your risk-free consultation, please type in yes and the best phone number to reach you at in the chat or Q&A box, and a scheduling coordinator will call you to set that appointment. Also, if you'd like to call in directly, the phone number is area code 253-205-8486. And you can also book your consultation online at www.soundimc.com. Yes, sir. Thanks for joining us. What's your question?
Yeah, no problem. Hey, what makes you a bad candidate for any of this stuff?
Great question. So contraindications. Basically, if you're on a very high dose of blood thinners and your INR or blood clotting score is too high, that increases your risk of a hematoma, a pooling of blood. So if you're on any high dose blood thinners that do affect clotting factor, not some of the newer medications like Plavix, but some of the older ones like warfarin or Coumadin, we would want to get an INR score to make sure that the injection itself would be safe. Even a simple needle puncture can be dangerous to people with higher INR scores. Other than that, a Baker's cyst is something that could be a contraindication. So that's where the capsule actually develops a fluid-filled cyst. And if you've got a large one, we would see that on the arthrogram. We might drain it and use a corticosteroid injection to dry that out before doing the injections. And you never know, that might even reduce your pain and symptomology. You might not even need to proceed after that point. And then something else we look for is a thing called a synovial tear. So when we inject that contrast dye, if there's a rupture in the membrane and the synovial fluid is leaking out, then we will apply a brace and give you recommendations for about 3 months of non-weight bearing exercise to allow that tear to heal. And most times your pain and symptomology will go away once that tear resolves. But if it doesn't, proceed to the injections. Other than those specific considerations, there's really nothing else that makes you a bad candidate. I mean, we've even had patients that were morbidly obese. I had a 512-pound patient. He was under 6 foot tall in Philadelphia. He was so large, actually, that we had to send him to the local zoo to get his x-rays. And his brace was made by a veterinary orthotist. But he went through 3 rounds of injections over a 2.5-year period, lost over 200 pounds, really had a wonderful improvement. So there's really nothing that makes you a bad candidate. Maybe makes you a more complicated candidate where a single round of injections might not completely resolve your problem. Those more severe cases that are bone on bone, in a wheelchair, morbidly obese, et cetera, may require a follow-up round of injections, which is covered by most insurance after 6 months, and some insurance like Aetna after only 90 days. Does that answer your question, Mark?
Kind of. I mean, for me, I'm severely bow-legged. I've been that way for quite some time. And I'm just wondering if you got those kind of things going against you, where there's plus I was active most of my life, climbed every mountain you can believe, skied for 50 years, played college football, all that kind of stuff. But I'm just wondering if I'm way beyond the point where anything really like this could help. I mean, I've tried the hyaluronic acid, but single injections and monovisc single injections. Couldn't tell if it helped me or not, actually.
So 2 points. One is with the single injections, it's like changing the oil in a car, whereas with a multi-injection protocol, it's almost like teaching that car to create its own clean oil over and over and over again. Part of the goal here is to stimulate those synovial to act normally again. You can't do that with a single injection. You've got to continually expose these glands to the hyaluronic acid to trigger them and stimulate them and get them to start producing that hyaluronic acid on their own again, so that joint fluid gets the consistency and the ability to bear weight back. So that's part one. Part two is if you've got a really significant misalignment in your joint like you do, you might have to have a custom knee brace manufactured for you. Now, we work with a company where we actually take a picture of your knee with an iPhone, we upload it to the website, and then a prosthetist and an orthotist will hand manufacture a brace for you. And the brace for the knee is not much different than the way a brace for your teeth would work when you were younger. It's designed to bring the bones back into alignment. So the tension on that brace will be increased over time to move the bone back and back and back and back into proper alignment.
Yeah.
If you have a significant misalignment, you may have to wear that brace for months, possibly even years. That 2-year outcome I showed you, she was wearing the brace for 18 months. Now, she was very severely degenerated. I mean, that's probably the worst case we've ever seen, which is actually why I use it in this presentation to show people that people that are worse off than you can actually still benefit from this as well. So you
Yeah, I
might have
mean,
more of a long-term process to get that alignment back, but I wouldn't write this treatment off yet. And then I also wouldn't say that knee replacement would be a guaranteed alternative, because when they replace the joint, they're replacing just the surface of the bones. They're not going to address that misalignment. So one way or another, you're gonna need to use bracing to reduce that misalignment at a minimum, correct it at a maximum, or whatever you do. Even a knee replacement surgery may not provide long-term relief.
yeah. All right. Hey, thanks.
Yeah, you're welcome, Mark. I appreciate the questions. They were very detailed. Thank you. Any other questions today? And I did forget to mention one thing while we're taking questions. Um, I'm often asked, is the procedure painful? Does it hurt? The answer to that is almost not at all. And the reason for that is we use two types of anesthetic. We use a spray called ethyl chloride. It's a vapocoolant, and it freezes your skin for about 10 seconds. So while we're puncturing the skin with the needle to inject a 2% lidocaine without epinephrine, you don't really feel that needle stick because of the coolant. And then we use 2% lidocaine, not 1% like most offices do, and it gets you very numb very quickly. So you typically will not feel the procedure being performed. The DO who injected my knee at one point, he said, close your eyes and tell me when I'm done. So I close my eyes and I say, I felt it. I think you're done. He goes, open your eyes. He's over in the corner of the room washing his hands. He goes, I finished like 40 seconds ago. I couldn't even tell he was doing it. So the anesthetics work really well. And then the video guidance keeps us from ever having what's called a bone strike, because we see the needle on approach. If it's approaching the bone, we stop. And if you've ever had a bone strike before, it's that really sharp electrical pain that almost makes you jump and say, ow. Those will be completely avoided because of the guidance that's used in our facilities. So that being said, I see we had one or two other hands go up. So let's try and take at least one, maybe two more questions before we adjourn for the day here.
Christine, go ahead.
Yeah. Hi. I have been the route of everything. Last thing I did was plasma-rich plasma at the University of Washington, which did help me. But I do have a cyst. I don't know what kind it is. I think it might be a Baker cyst. So will they be able to drain that then? I mean, I know that when the doctor at the University of Washington, he saw the cyst, and he said it was so thick. I was watching him do it. It was so thick that he couldn't get it all out. So I don't know if the cyst is I've had multiple sports injury, then car accidents, and the first meniscus I was 31. That was the first meniscus surgery. I've had 3 others after that, 2 in both knees total. And I'm just destroyed with arthritis now. And I live on a farm, and so it's really hard for me to, get out there with my horse or my other animals. It's just, the pain is horrific, and it's daily. It never goes away. And so I made an appointment for Friday to come in. So
Well,
I'm not sure which.
thank you for your question. I'm glad you booked your consultation to get a second or third opinion before you consider surgery or any other alternatives. A couple things I have to understand the question there. First is with the cyst. There can be a Baker's cyst, there can be a popliteal cyst. Sounds like you have a Baker's cyst. If it's becoming fibrotic, thick, like the doctor said, Baker's cysts go from active, where they're fluid filled, to calcified, where they become solid. Once they become solid, the body will slowly reabsorb that by using these structures called macrophages and monocytes, these little cells that go through your plasma that will eat up scar tissue or abnormal tissue, reabsorb it, filters through the body, through the liver, out in your waste. So you might be at that stage where that Baker's cyst is transitioning from active to calcification. If it
Yeah.
calcifies, that usually winds up being a good thing for it to be reabsorbed by the body. It's when they're active that they're more painful and dangerous. So
Yeah,
one,
I think it's still active because I can't even hardly touch it. Like right now I'm moving it back and forth with my fingers and it's a killer. So,
so PRP will actually make a cyst worse because the first thing that platelet-rich plasma does is it creates inflammation because you're concentrating your white blood cells. Your body interprets that as a new injury. And it brings vascular blood flow to the area. Really
uh-huh.
good for tissue regeneration, but it is not anti-inflammatory. It's actually inflammatory. So that can actually exacerbate a Baker's cyst. Now that might have helped your cartilage and the structural damage, but it could have actually aggravated this a little bit. Typically, when you have a Baker's cyst, we'll do the effusion, the draining of the fluid, and the injection of a corticosteroid, usually a stronger, longer lasting one like dexamethasone. And then two
Uh-huh.
weeks later, do the first injection of viscosupplement so that we reduce or eliminate the cyst before the injection of hyaluronic acid takes place. But that's just a general overview. Dr. Fobi and his team are going to be able to give you some specific feedback on your cyst.
Right. I do have a question about those injections. Are those have those injections been called rooster comb injections also?
Sometimes people call it that. Those are from the original medications like Hyalgan and Suparts. They were derived from the comb of the rooster where it
Yeah,
was purified and concentrated. Since then, how
it's
these
changed.
medications are produced, it's a lot different. Yeah,
Okay,
synthetic.
because I had those also.
Yeah,
I
synthetic manufacturing was the next step, and then this bacterial culture process was after that. So the products that we use are mostly from bacterial culture, and they are a higher molecular weight, so they're more dense than the original visco
okay.
supplements. Because they're not derived from an animal, there's no potential for allergic interaction. So there's also more active ingredient. There's 25 milligrams.
Okay, so they've come a little bit further with stuff than when I had that, which was
Advanced.
it's had to
There's
been 8 years ago.
medicine around this now called orthobiologics. And there's whole conferences just on orthobiologics. Every year there's one in Chicago, actually, the TOB.
Okay.
Did it virtually this year. But,
Yeah,
it's
so far I just wanted to ask about, I'm not sure what kind of cyst it is, but I know that what it does to me is on the inside of my leg, like on the inside, it does something where it pulls. It's like a pulling feeling, and it's so painful. I don't know how I even deal with the pain. I
that
mean, I
is probably pushing outward on your ligaments, like your anterior cruciate ligament, and then you're feeling that extra pressure because that ligament's being pushed as you go through your range of motion. On physical examination, they will be able to probably narrow down exactly how that's behaving inside you and give you a good recommendation for course of care.
yeah. Is there any way, like with the consultation when I come in there, do you know if I'm just wondering if I could start some kind of like at least get my cyst drained if or do I have to come back?
No,
Probably
it's
have to
possible
come back.
it can be done on the same day. It is possible. They're going to go
I
through a
hope
physical examination first and the
I hope.
X-ray and make sure you're a good candidate for it. But if they find an effusion that needs to be drained, they're not going to put it off.
Oh,
They'll
I hope so because at 61 years old, going from say just the last 4 years, or no, three, almost four, I was so active year before last, constantly moving, going, swimming in my pool, out in the field on my tractor, with my horse and all my other animals, to now I can barely get out of bed. I don't even want to get out of bed because I know the minute that I start to walk, my left knee is just going to send me through the roof. then I was so desperate, I went to a pot store. I don't smoke it, but I got this rub, and I got THC and CBD, right? And I just said, give me this THC, because I don't want THC, but I got it, and it has helped somewhat. I wouldn't say 100, but it's helped a little bit.
Those topicals can be helpful. When we use the topicals, we tend to order them from a compound pharmacy, and they're usually diclofenac based, which is
Yeah, that's for arthritis. I've got a jug of that too. Trust me, I have so many different things. I just want to get
it's down in there like a few inches, right? And you're trying to treat a topical, so it's usually a little more effective to get in at the site of the injury and do some direct treatment, which is what you're going to be evaluated for.
So maybe I should try the difocalnac then.
The diclofenac might be covered by your insurance. They can go over that with you when you come in.
No, I've got some. I have a tube of it.
So
So
that's
I'll
in most arthritic cases with the inflammation aspect of it, but
yeah.
you've got a loss of some of your structural components too. So again, this goes back to the corticosteroids, the anti-inflammatories, these topical creams. Those are all treatments for symptoms, not solutions to the underlying cause. So that's what we're going to try and work towards during your consultation when you go in to meet with a team.
So would you suggest, Lance, that from now until Friday to not use the CBD and go for the difocalnac that I do have?
Well, I would continue whatever works best for you. If you're getting good results from the CBD product, stick with it. If that's not giving you results and you want to try the diclofenac that's been prescribed to you previously, I mean, it's trial and error. Think of when you got to use an NSAID.
Yeah, I've been
with
to hell and back with this left knee. Trust me.
So whatever your body responds best to, that you've been prescribed, I would stick to what's working. And then also just 2 points I want to cover. How you've been moving less, that actually makes the problem worse because the synovicytes are stimulated by hyaluronic acid and by weight-bearing function.
Right.
So this is actually going to cause your condition to spiral and progress faster. And then secondly, oh gosh, now I lost my train of thought. We're going through so much stuff here.
It's okay. I do have a swimming pool, an above ground, pretty big one, but it's just not uncovered.
You're going to find the brace to be helpful too. If you've not used an unloading brace before, that's going to provide some immediate relief and some return.
What kind of brace?
We use an unloading knee brace. It's a single hinge unloading knee brace, and it can provide some immediate relief, especially when people have significant loss of joint space in one of the two compartments, not both.
Yeah, I have it in one, I believe. I do have a brace that somebody made. I don't know. It was a guy up in Seattle, and it's a heavy duty plastic. It's just too much for me, so I don't even wear it, but maybe I should.
The brace that we use, I'll go back to, I think I have a small image of it here. So the brace that we use is under 2 pounds. It's very lightweight and low profile. It can be worn under clothes, including under jeans. And it's very effective at producing an increase in joint space. It's also lined in closed cell memory foam, so it's very comfortable to wear. And it's adjusted to fit each individual. I've kind of zoomed in on it here. You'll get an opportunity to see that when you go in for your risk-free consultation on Friday.
That looks a lot different than the one that I have. The one that I have, I tried it, Lance, and I was like, no.
That go on both sides. And those are really more for sports injuries and ligament injuries, not necessarily for degenerative osteoarthritis. It's actually why we went into manufacturing that brace 8 years ago. There was nothing on the marketplace that moved the tibia and femur apart and did not restrict range of motion. Most of these braces, they actually keep you from using your knee in its full range of motion. Well, if you have OA, you've lost range of motion. You don't want to restrict it further. So we actually developed a patent pending, PDAC approved, covered by Medicare brace specifically for this.
I've got Boeing insurance, so I'm good on insurance. But I do walk with a limp, but it's and I do have to feed my horse, and I do have to clean a chicken coop, which I haven't. I need to do it today, but it's excruciating pain. It's really debilitating and it's very depressing. And in high school and all the way out of high school, I always did really heavy duty, hard jobs. I never was like a girly girl, more like a tomboy. And so I did a lot of, like tire busting at Sears, that kind of stuff. So I probably kind of,
You can
I
work through
don't
the
know.
burnout a little quicker that way. There's a fine
Yeah.
balance between not enough exercise and too much exercise. But
Well,
hopefully, we
yeah.
can practice some more active movements again after your evaluation, hopefully successful treatment. So,
Yeah.
with that said, we're running a little short on
Okay.
time here. I just
Thanks,
want to,
Lance.
you're welcome. And I hope you have a good consult on Friday and this works for you as a
I do
good.
too. I think it will. I don't even know how I stumbled into found you guys. None of it. I don't even know how I found you guys, but I'm glad I did. So
So,
thanks a lot, Lance.
one last time, I'm going to repeat the contact information to schedule your risk-free consultation. Again, you can type yes into the chat or Q&A box along with the best phone number to call and book your consultation at. Or if you want to schedule over the phone, it's area code 253-205-8486 or online at www.soundimc.com. I want to thank everybody for taking time out of your day to meet with us here today. I hope you learned some new information about osteoarthritis and your potential treatment options, especially if you've been told your bone on bone and surgery is your only option. I find those terms to be grossly overused in our US healthcare system. I was told I had no other option. This worked for me, saved my knee, changed my life, changed the trajectory of my life. That's why I'm here sharing my story with you and talking about these treatments. And again, just want to thank you all for taking the time. Please take advantage of the risk-free, no-cost consultation, even if it's just for the peace of mind of having a second or third opinion before you make the decision to go under the knife with a surgical procedure. It's always best to have a clear mind and a clean conscience going into those procedures if necessary. That being said, the majority of people, almost all, can have some reduction of pain, improvement of function, and delay or avoid their knee replacements with the advanced arthritis relief protocol. So again, thank you for your time. I hope you enjoy meeting with Dr. Fobi and his team at Sound Integrated Medical Center. I've interacted with them. They're great folks, highly experienced, trained, and certified. So they'll take great care of you. And I hope you can find relief from your condition just as I was able to and to achieve a successful recovery. Thank you again for your time. Please reach out and schedule those risk-free consultations. And again, I wish you the best of luck in your treatment and health.